And I'd like to begin by thanking IOP Publishing and Modus QA for hosting this event. I'm very excited to present this project and our research. Stereotactic body radiation therapy is an effective treatment for early stage non-small cell lung cancer. And so clinically, it's been shown, and it has become the standard of care for treating medically inoperable lung cancer. And actually a lot of evidence out there points to the fact that we might even consider SBRT as an alternative to surgery. SBRT uses large radiation doses delivered in a few fractions, and it requires accurate target localization. Our linear accelerators can deliver radiation with an accuracy of around 1 millimeter, but due to breathing motion, our tumor can move as much as 2 cm. One of the techniques that we use to account for this breathing motion is, for example, the physician may contour the gross tumor volume, the GTV, and then either add on a pre-subscribed margin to account for internal motion to create the ITV, or use a 40 CT to actually contour out all of that motion that we would expect, and then add on an additional margin in the form of a PTV, or planning target volume. And as you can see, the target that the tumor that we're trying to treat is actually much smaller than our overall planning target volume. And so there are some areas of improvement for lung SBRT treatments. One of which is that even with our best attempts at immobilizing the patient, irregular breathing may cause the radiation to miss the tumor, resulting in lower than intended target doses. And it has been shown, for example, in this publication that our 40 CT may not actually capture the full range of motion of our lung tumors. Also, as I was mentioning before, due to this internal target volume expansion, normal tissue is actually included in our target volume and will receive full ablative dose. And so this publication showed that if we were actually able to reduce and just treat this gross tumor volume through a number of techniques that I'll describe later, we could perhaps reduce this PTV volume by a factor of maybe 50%, which would allow us to spare normal tissue and also spare organs at risk that might be close to our tumor. In order to improve upon SBRT, we can use something like real-time imaging, which would allow us to pinpoint the location of our tumor throughout treatment. And so shown here is an example of if we have some sort of guidance, we might be able to identify if our tumor is leaving our intended target volume. So shown here in the cartoon, our tumor is leaving our treatment beam, as shown with this blue. And if we had some image guidance, such as scatter imaging, we might be able to stop our beam if we find ourselves in this situation while treating the patient. We can also think about tracking the tumor with either MLC tracking, in which case we could reduce our PT volume to just conform to our target, or through couch tracking, which would counteract any breathing motion by moving the entire patient body, so that again we can just target the PTV. So these are some of the things that we hope to do with real-time imaging. So the goal of this project is to really develop a markerless tumor tracking technique. Markers provide toxicity when implanted in patients. And unfortunately, a lot of the standard imaging techniques that we have at our disposal, so for example, KV or MV imaging, have some disadvantages. So KV has low contrast of soft tissue. It also delivers an additional imaging dose to the patient. Portal MV imaging is nice because it shows us the beam path that the radiation beam is taking through a patient. However, it also provides low contrast of soft tissue, and it's only a 2D projection, which prevents 3D imaging. Scatter imaging has a number of advantages, which I'll talk about a little bit later. But really, the origin of scatter imaging is that when we irradiate a patient with our MV therapy beam, photons are scattered in all directions surrounding the patient due to Compton scattering, which is actually the dominant interaction between MV therapy beams and tissue. And so I sort of mentioned our goal, but our hypothesis is that by collimating these scattered photons with a pinhole collimator, we can achieve real-time imaging of the treatment volume and then use those images for tumor tracking. And so some of the advantages of scatter imaging are that it can be collected in real time. We're using photons delivered during treatment in order to form our images, which means that we can collect them almost instantaneously. The imaging technique is high contrast because only the irradiated tissue scatters. We can think about our LINAC as being a very high energy flashlight that we're using to illuminate our patient, and only photons that are scattered out of that beam appear and reach our detector. So it's very high contrast. Both the treatment volume and the beam path are imaged. There's also no additional dose, again, because we're using photons that are used for therapy. And although in this cartoon we're only showing one camera collecting these scatter photons, because the photons are scattered in all directions surrounding the patient, we can place cameras at multiple positions around the patient to collect multiple simultaneous images from many viewing angles, which opens the possibility of doing three-dimensional image reconstruction and a three-dimensional identification of our tumor position. There are also no fiducials implanted in the patient because we rely on the electron density differences between our high-density tumor and our low-density normal tissue to provide our contrast in our image. And that is because Compton scattering is proportional to the electron density of our material. Some of the disadvantages of this technique, as I will show you later, are low photon counts, and also unirradiated portions of the tumor do not appear in the image. So if we use our multi-leaf collimator to modulate our beam, some parts of the tumor may not receive dose at all times, and that means that we will also not see them in the image. They will be shadowed by those MLCs. Now, in this presentation, and a lot of our work is focused on applying scatter imaging to SBRT lung treatments, and that, as I described before, is because there's a need to track the tumor that can improve our ability to treat the patient. However, we could use this technique for normal lung irradiation. However, SBRT provides very high dose rates, which means that we can maximize the number of photons that can be collected at relevant frame rates. Lung is also an ideal site because there's a large density difference between the lung tumor and the surrounding tissue, which results in high contrast. We can identify the tumor and distinguish it from the surrounding healthy lung. Now, we're not the first group to work on scatter imaging, and so shown here are just a couple examples of previous and current work that's being done in the field. Shown here is an image from a paper by Leal from 1959, in which he proposed using scatter imaging to map out a three-dimensional density within a patient. So using a pencil beam of radiation and a properly configured collimator, you could measure the photons being scattered out of a particular voxel and then raster scan this beam or the camera to build up a three-dimensional picture of our patient. And this was actually explored for decades as an alternative. Really, there was no CT at the time, and so this was a way to map out internal anatomy in a three-dimensional way, and also map out electron density, which is useful for radiation therapy dose calculation purposes. More recently, we're focused on using a pinhole collimator. There's a group at the University of Colorado, shown here, which are developing other imaging techniques based on coated aperture. And there is also a group at UT Southwestern that's using KV irradiation in order to perform scatter imaging. So this is a brief outline of the rest of my presentation. I'll be talking about some of the analytical simulations that we've done, moving on to preliminary feasibility phantom experiments, and then finally patient images that we've collected. I wanted to talk about this analytical simulations because I think it's valuable. It helps us characterize the underlying physics, and I hope to be able to answer the questions of what will we expect scatter images to look like, what sort of photon energies are produced, which informs what sort of detectors we want to use experimentally, and then also what kind of contrast can we expect. And so the analytical simulation method that we developed here at Rush relies on a ray tracing algorithm. And there are really three steps. The first is performing that ray tracing, where we have some incident beamlet of photons. They interact with our patient and are attenuated, which we can calculate with some sort of exponential or entrance attenuation. And then we can analytically solve or calculate the number of photons that are scattered in all directions from this point B, based on knowing the electron density of that point B and the energy of our incident photons and the Compton scattering coefficient of this particular voxel. After that primary scattering interaction, things become a lot more complicated, and it becomes difficult to calculate multiple scattering events because there are just so many photons that we'd have to keep track of. So in order to speed up our simulation times in comparison to a full Monte Carlo simulation, we actually rely on a superposition convolution algorithm, which uses a 1 over r squared kernel to account for multiple scattering and the fact that the fluence of those photons that are generated will fall off with that 1 over r squared dependence. We also account for attenuation in our model using a Taylor expansion approximation. Once we've accounted for all that multiple scattering or modeled it using the superposition convolution, we then form an image by, again, using ray tracing to form an image using a pinhole collimator. And so in order to validate this analytical method, we actually perform matching Monte Carlo simulations using these two phantoms, which are shown here. A simple lung tumor in which a cylinder of water is implanted in lung tissue surrounded by some more water with a pinhole collimator placed above. We also used a patient CT image and modeled what a scatter image might look like for a pinhole collimator placed anteriorly. And in all these simulations, we assume that an ideal pinhole collimator and an ideal detector are used, and the images are noiseless. So shown here are some of those images. Because we're irradiating because we've placed our detector above our patient or above this simple phantom, what we end up or would expect to see in our image is a projection of the irradiated volume up into the detector. And so this means that what we're seeing is essentially a projection of the coronal slice. And when we compare our scatter images that we have simulated to those, the CT on which we perform the simulations, we see that these scatter images look a lot like what we expect to see. That is to say, they look a lot like the coronal slices from the CTs. Shown here in the upper row are those Monte Carlo simulations and the analytical scatter image simulations, in which we can see different pieces of anatomy. So for example, the entrance chest wall, this lung tumor phantom, and the mediastinum, and then again, the chest wall, lung tumor, and mediastinum in the actual patient images. If we look at profiles taken through along the horizontal and vertical lines through these images, we see good agreement between our simulated and our analytical, or our Monte Carlo and our analytical simulations. We can also look at the spectra which are generated through the simulations, which show that when we place our detector orthogonal to our radiation beam, we collect photons that peak at around 140 to 220 keV and tail off at around 750 keV. In order to get a sense for what these scatter images might look from different angles, we placed our camera at multiple positions surrounding the patient, performed the simulation, and these are those resulting images which show that even from many different angles we can see the tumor, and it also gives opens the possibility for doing 3D image reconstruction. We also calculated the contrast in our scatter images and compared it to the contrast that we simulated in a transmission MV portal or EPID image. The contrast is measured by the tumor intensity minus the surrounding lung intensity divided by the tumor intensity is shown here in this graph as a function of field size, where for an MV portal image, we expect to see poor transmission compared to the transmission or the contrast that we would expect for a scatter image. And that is largely due to the fact that the transmission image projects all of the patient anatomy between the source and the detector onto that detector, which means that you have a lot of confounding anatomy, a lot of signal coming from the chest walls, for example. Whereas in scatter imaging, if you're only irradiating a thin slice of the patient, there's higher contrast, there's less anatomy, which can muddy the image. So moving on, we also performed a set of phantom experiments in order to determine the tumor tracking potential accuracy. So shown here are very initial experiments in which we used a nuclear imaging pinhole collimator with a CR plate detector placed on top, which is not shown in this image, irradiating a phantom which is shown digitally here, the same digital phantom that I described before, in which we have this cylinder of solid water implanted in a cork to account for normal lung tissue, surrounded by some additional water. And the scatter images shown here look a lot like those that we were simulating, where we're in these views we're radiating from above in these images. Higher intensity corresponds to more photons that are being scattered out of the initial chest wall phantom. Then we see our normal tissue producing, or normal lung tissue producing lower numbers of photons because of its lower electron density. Our tumor in the center, which we see very brightly, and then the mediastinum. The intensity falls off as the beam passes through our phantom due to exponential attenuation. So the entrance side is brighter than the exit side. In these initial experiments, we irradiated our phantom with various numbers of mu and looked at the resulting contrast to noise ratio. Because we're using dose rates of 1200 mu per minute, there is this relationship between the number of mu that we can deliver in a relevant time frame. So for example, from task group 76, we would like to be able to track a tumor and identify its position within half of a second in order to be able to act on that information in a meaningful way. So for example, if we spend 250 seconds collecting an image of a lung tumor, our treatment will basically be over. We need to be able to collect quality images at quickly. So half of a second, sort of that threshold, we need to be able to identify the tumor and act on that information within 0.5 seconds. And from these images, we see that a 10 mu of radiation gives us a fairly nice image. From these initial experiments, we also observed that there's quite a large background in our images. So if we place our phantom underneath our pinhole collimator with our detector above and irradiate, we get an image that might look something like this. If we remove the phantom and irradiate again and collect, we actually see quite a number of photons. Shown here is an intensity profile in orange, which shows that sort of half of the photons that we might collect for any particular configuration of a pinhole collimator are actually not originating in the phantom. And so shown here in brown are some of the different types of photons that we expect, the ones that we want, which come through the pinhole collimator from our phantom. Ones that we don't watch, which might come from the phantom but penetrate through our collimator. And then the ones that are really responsible for this background are those that are either leaking through our gantry head or being scattered off of the jaws of our collimator and create this large background. And so all of the images that I will show moving forward have actually are subtraction images in which we collect an image with our phantom or with our patient, and we should subtract a background which has been collected previously without that phantom. So we started out with that initial phantom, and we moved on to more complicated phantoms to prove the feasibility of using this technique for lung SBRT tumor tracking. In our first set of experiments shown here, we use a LUNGMAN Phantom, which is an anthropomorphic phantom, which is anatomically accurate, it's life size and radiographically consistent with our patient. Into this lung, we implanted a roughly spherical lung tumor, which was made of thermoplastic beads with a density close to water. And we used a variety of diameters in order to characterize the scatter imaging quality. This is nice because it's similar to a patient. However, the lung density of the tissue inside is just filled with air, so it's a very low density compared to what we expect for healthy lung tissue. We also used a QUASAR phantom, which is a device produced by Modus QA in order to perform dynamic experiments. Although we applied a sinusoidal motion along a superior inferior direction, this device is capable of applying an arbitrary waveform with movement along multiple axes. In order for our experiments, we again created a lung tumor phantom out of a thermoplastic beads, which were then implanted in polyurethane foam to produce a lung tissue density that's slightly lower than what we expect in a healthy lung. And for these experiments, we applied sinusoidal motion of 15 breaths per minute with an amplitude of 1.5 cm. And this is the imaging system that we use to image these two phantoms. Again, we're using a pinhole collimator that's been scavenged from a nuclear imaging system. We added additional Saraband to try to block as many of those unwanted photons as possible. Instead of using a CR plate, as described before, we now use an X-ray flat panel digital detector, in this case with a scintillator of 550 micron cesium iodide. We placed our phantoms underneath, irradiated from the side with both fixed beams, so static beams, and then also with some rotation for conformal dynamic arcs and VMAT modulated arcs. These are the results of those LUNGMAN Phantom experiments, in which we're irradiating from the phantom's right side, collecting images anteriorly. And so what we expect to see in our scatter images is very similar to what we see in a coronal slice of our CT. Shown here are those scatter images collected for various MU, ranging from 2 to 100 MU for a diameter of 2.1 cm lung tumor. If we look at these images, in particular the 100 MU image, where we've really used a lot of dose to reduce the noise, we can see this entrance chest wall, which is corresponds to over here in the CT image, the tumor at center, and then the mediastinum on the right side of the image. As we decrease the MU, our noise increases. And shown here on the right is the contrast to noise ratio as a function of dose, which shows that we have higher contrast to noise ratio for larger diameter, but even for our smaller 2.1 cm diameter, we can still achieve a contrast to noise ratio of 4.4 with a dose of 10 MU, which again corresponds to 0.5 second integration time for a 1200 MU per minute beam. In our next set of experiments, we used the QUASAR, this dynamic phantom. However, we began by doing static positioning, where we stepped the position of our lung tumor, collected images, and then stepped to another position. We simultaneously collected scatter images with 100 MU, so again, placing our detector anterior to the phantom. However, we also collected an MV image as well to provide a ground truth measurement of where the tumor is, and then compared the position from the MV image to the position that we extract from our scatter image. The results of that are shown here, where we see a root mean square error of 0.2 millimeter between the MV determined and the scatter image determined positions. And so this set of experiment really gives us a best case scenario for how well we'll be able to identify tumor position using our scatter images in this particular setup. Because we're using 100 MU, which is a much higher dose than we would be able to image in a single frame for a patient. And just so a little aside on how we actually identify the position in our MV and our scatter images. For our MV images, which are providing our gold standard information for where our tumor is, we use template matching, which we use an image of our tumor collected on some standard image, and then perform a convolution or a cross correlation with our raw image to identify a maximum in that cross correlation that identifies the position of our tumor. For scatter imaging, where we have no modulation, that is to say an open field, we use a similar template matching technique where we convolve with a Gaussian generated to match what we expect our tumor to look like to create this cross correlation image. However, rather than just looking for the maximum value in this cross correlation image, we actually fit a Gaussian to this cross correlation image. This allows us to get sub-pixel level precision in our matching. For scatter images with modulation, which I haven't shown you yet, but I will show you in a couple of slides, there's the shadowing effect where perhaps an MLC is blocking part of our beam to create the modulation, and that creates some shadowing within our image, as shown here. And this can complicate the procedure that I described before, this fitting procedure, because our tumor, part of it is being shadowed, which means that if we just fit it to a Gaussian, we will get an inaccurate measure of its position. So in order to account for this, we perform similar cross-correlation with this Gaussian template. We then apply further image processing to sort of highlight intensity within our image by calculating the Laplacian. And then we assume that the scatter image that we get of our tumor is the product of the initial fluence multiplied by some Gaussian, what we expect our tumor to be. And so this initial fluence we measure experimentally by just projecting the entrance dose, or by projecting the entrance fluence, which we assume to be proportional to the scatter imaging intensity that we observe on the entrance chest wall of our phantom. So we use this as a surrogate for the fluence reaching our tumor and allow the fitting routine to move the position of our Gaussian multiplied by that fluence profile and fit it, the resulting shadowed tumor, to what we observe experimentally. And so here's some results of our next set of experiments in which we're actually doing dynamic experiments, where we move the tumor with that 15 breaths per minute sinusoidal motion using our QUASAR phantom. We identify the position on our MV portal image as using the algorithms described in the previous slide, and then also fit our scatter imaging. And what you see here is this sinusoidal motion on the MV and on the scatter image data. We then, in order to match them, we extract a sinusoid from our ground truth data and fit it to what we measured with our scatter imaging. And so for this example, where we're radiating with an open field with an integration time of 300 milliseconds per frame, we see a root mean squared error of 0.7 millimeters. So we're able to get sub-millimeter accuracy with our scatter imaging method. From our open fixed field delivery, where we're fixing our gantry position, irradiating, and collecting images, we see this root mean square error across multiple trials of between 0.7 and 0.9 millimeters for 300 millisecond integration time. And when we increase that integration time, this root mean squared error decreases just because the images become less noisy, down to 0.6 millimeters. We also perform these experiments not with a fixed field, as in the previous slide, but with a rotating gantry with both a dynamic conformal arc, which is shown here, in which the MLCs have been conformed to our PTV, which is based on an average 40 CT. And those results are shown here, where our MV portal image looks a little bit different because we have these MLCs conforming to our PTV. The scatter image looks similar, and when we perform our fitting routine, we find a root mean squared error of 1.2 millimeters. And then finally, with this phantom, we also performed or irradiated with a VMAT plan across a partial arc, collected the same MV and scatter images. And so shown here is the MV portal image, in which you can see some shadowing of in our scatter images due to the fluence being modulated by these MLCs. And as a result, our root mean squared error decreases, or really increases, becomes worse, it goes up to 2.9 millimeters. This is a summary of these initial phantom experiments, in which, again, if we can irradiate with quite a few MU, we can achieve 0.2 millimeter precision in identifying the position of our tumor from our scatter images. When we start introducing motion and collect images on relevant timescales, that is to say, 300 milliseconds, our precision increases to 0.9 millimeters. If we're delivering a conformal arc plan, increases again up to 1.2 or 1.4 millimeters. And then finally, if we irradiate it with a VMAT plan, our precision goes up to 2.9. Ideally, we'd have a precision in the 1 to 2 millimeter range. And finally, I'd like to discuss some of the patient images that we have been able to collect. In the previous Phantom experiments, we used this setup, this wooden frame with this camera shown here. And so one of the first things that we set out to do based on those initial Phantom experiments was to design a new camera which would improve upon our old camera. And the results of that effort is shown here, in which the individual components are the same. We have a detector, at least in this view, shown at the base, and a pinhole collimator on top. The detector that we've purchased is an X-ray flat panel detector using a 700 micron cesium iodide, so a little bit thicker scintillator. And the pinhole collimator itself, rather than using just this old scavenged pinhole collimator, which has a lead thickness of around 7 to 8 millimeters, we can actually configure this in 3 different setups. One in which we've added an additional 7 millimeters of lead, and then one in which we've placed another jacket of Saraband on top to create a lead equivalent thickness of 35 millimeters, shown here. And so by doing that, we can actually increase our image quality, reduce the noise considerably. So shown here are the same Phantom scatter images collected with those 3 different configurations of pinhole collimator, in which we can achieve a 3.6 increase in contrast to noise ratio by adding all of that additional Saraband in this so-called C configuration. We also worked on developing a way to mount and position our camera. And so we have 2 different mounting methods. The first is using a crane, which provides 5 degrees of freedom in positioning this close to our patient. We also have this track system in which we can move the camera underneath our patient during treatment, so as the gantry is rotating, which allows us to place it as close to isocenter as possible. Under an IRB approved study, we've collected scatter images of 9 patients undergoing SBRT lung treatment, one of whom was treated to both the left and the right side. We've imaged during VMAT and dynamic conformal arc experiments with different sorts of fractionation. And we've experimented with many different camera positions, particularly for this crane. However, the crane only allows us to get within around 50 cm of our isocenter. And so the track system, as I said before, the advantage is that it can really get much closer to their patient, which increases the number of photons that we can collect and increases our spatial resolution. For the studies that I will show, we collected images at a 2 Hertz camera frame rate, so 0.5 seconds per frame, corresponding to 10 MU per image. And what I'm going to show are just a set of 4 patient images, which I think are particularly interesting. So these are the images that we collected for our first patient, actually. And there's a lot going on here, so give me a moment just to explain what you're seeing. This stick figure in the lower left corner shows the field of view, or the point of view of our camera. So in this situation, we've used that crane to position the camera in the right inferior posterior position relative to the patient. And this gray box sort of shows the plane through which the gantry is rotating and irradiating, and shown up here is this CT axial slice, again skewed to show the view of the camera. And so we're sort of looking at this strange oblique view. Blue indicates the beam and the gantry angle for all the particular frames that are being shown in the center of the slide. At the top are simulated scatter images using our analytical simulation technique, in which the fluence of the beam has been modified to match the control point MLC positions. And on the bottom are the actually experimental images that we collected. So these are experimental scatter images collected during lung SBRT treatment. And we deliver this plan in 2 arcs, which means we have 2 movies of data, which are shown on the left and the right, arc 1 and arc 2. However, we've reversed the order of the video for arc 2 so that it matches that of arc 1. So we're sort of getting we should be able to see the same anatomy in both views, although the images will be different because the control points used to irradiate the patient are using different MLC apertures. And so these images, if you look, are noisy and they are blurry. And so I'll describe some of the work that we're hoping to do to improve them. But looking at these, I'm always amazed because we're basically looking at our therapy beam interacting with our patient, which I think is fairly unique. Perhaps Cherenkov imaging would give us a similar view, although mainly of the surface, but we're actually looking at photons being scattered out of our beam by our patient. If we freeze at a particular frame of our movie, shown on the left is a CT slice corresponding to particular scatter images that we collected and the simulated images. And by comparison between the clinical and the simulated images, we can begin to identify some of the anatomy here, including the chest wall, marked in green, the tumor itself, and then some of our support structures, so the couch. This is actually the same patient, but a slightly different camera view. Another anatomical site that we can identify is shown here. This patient has a collapsed lung, and so at one particular gantry angle where we're radiating through this collapsed lung, there's a lot of intensity up here in that region, as shown both in the experiment, the clinical images, and also in the simulation. However, if we wait for the gantry to rotate another 6 degrees, we're now irradiating through healthy tissue, and we can see an absence of intensity there corresponding to that lung tissue. Because mounting the camera to that gantry, or I'm sorry, to that crane, limits the proximity of the camera to the isocenter, we spent a lot of time developing that track system that I described before. That allows us to bring the camera closer and to collect more photons at higher spatial resolution. And so these are the results of our first attempt with that tracking system, where we place the camera underneath the patient, which means we're looking posteriorly up from behind the patient. We're irradiating from the patient's left side to a tumor, as shown here in this CT coronal slice. If we look at these images, we can identify the chest wall, the tumor, and the mediastinum. We can also see shadowing within these images from the MLC modulation. And one of the interesting results of looking at this is if we compare multiple fractions, we can actually see that the diaphragm appears in some of the images during the irradiation from fraction 2 and fraction 3, which was not intended, at least based on our simulation images, showing one application of this technique, that if we can identify that the tumor is leaving our beam or that an OAR is entering our beam, we can perhaps take some action to prevent, for example, irradiation of the diaphragm in this case. So this is another patient. Again, we're treating to the left side and collecting images using that track system, which allows us to place our scattering imaging camera directly underneath the patient. And this patient, I'm sorry, I don't know if I mentioned, but this previous patient was a breath hold patient. This patient is actually a free breathing, and ideally we'd be able to identify the position of the tumor within the scatter images here. We've not been able to pinpoint that position yet, but we have been able to identify some breathing motion as described in this slide, where if we integrate the chest wall, superior and inferior portions of the scatter image, and we integrate the tumor, superior and inferior regions, and then we look at the ratio or the difference of the ratio between the tumor and this entrance dose, which is what we were doing previously in order to identify the position of our QUASAR phantom lung tumor in modulated plans. That is to say, we're correcting for the fluence that's reaching tumor over here by dividing out by the fluence that we observe on the chest wall. Then we can actually see some oscillations in our in this calculated intensity as a function of time. By comparing fraction 1 to fraction 2, for example, this red and this green line, we can see that the oscillations that we observe are anti-correlated, which suggests that there was a different phase to the breathing on these different fractions. We also see that the oscillation frequency corresponds to a period of about 5 seconds, which is typical for a patient breathing, for example, with a breathing rate of 12 breaths per minute, which is pretty typical. And so, yeah, based on these oscillations that we see, based on the fact that they appear to have different phases on different days, we attribute them to actually observing breathing motion within the patient. Of course, this is the first step towards our eventual goal, which would be to quantitatively identify the position of the tumor within 1 to 2 millimeters. However, it's encouraging. And so some of the efforts that we are working on in order to improve our image quality so that we can achieve that 1 to 2 millimeter accuracy of identifying tumor position are using a thicker scintillator in our camera. Right now we're using 700 micron cesium iodide, which is really optimized for KV imaging, diagnostic imaging, whereas the energies of our photons can range from 200 keV, well, it can peak at around 200 keV for an orthogonal position of our pinhole camera relative to our incident beam, as shown in our simulations. So we have actually done some preliminary experiments, which we have some 2 cm thick BGO crystals, which were attached to, placed on an amorphous silicon readout. And shown here in green are that image collected with BGO compared to the image shown in red, which was collected with the cesium iodide. We can look at the contrast to noise ratio, and we get about a factor of 2 improvement by moving to these thicker BGO crystals. We're also looking at methods for placing our camera as close to the patient as possible. So we hope to get funding for a robotic arm such that we can position the camera very close to the patient and move it dynamically around the patient to avoid colliding with the gantry during VMAT arc deliveries. We've also been exploring different collimator types. So all of our work thus far has been using the pinhole collimator. We propose using a parallel hole collimator. Parallel hole collimators have the advantage of, these are some simple calculations showing the full width half max, so the spatial resolution of the function of distance between our lung tumor and our camera. And then on the right here is the number of photons measured as a function of distance. But parallel hole collimators have the advantage of collecting photons. The number of photons they collect as a function of distance is independent of distance, whereas pinhole collimators have a very severe drop-off in the number of photons that they can collect. And so our Phantom experiments were done at a fairly close distance where we think we were collecting quite a few photons. Now that we're forced to move our camera further away due to preventing our camera from running into the patient or the gantry, we are actually collecting fewer photons, which is one of the reasons why our images look worse for our patient studies than they did in our Phantom studies. We can also, with parallel collimators, retain a lower spatial resolution, even at larger distance compared to our pinhole collimators. The other issue, aside from image quality, that we identified from our patient and Phantom studies is the fact that this modulation is complicating our ability to identify the position of the tumor. And in order to account for that, I just briefly wanted to describe this slide where there are cases where even if we have quite a bit of modulation, we can still see quite a bit of the tumor in our image. So shown here is a highly modulated field irradiating a tumor. And then shown here are the scatter images that we simulated for this modulated field, in which we can see all parts of the tumor, because all parts of the tumor are being irradiated, although only portions of them are being irradiated. And if we compare that image to that which we collect for an open field irradiation, we can see many of the similar features in these two. And so even if we're irradiating this particular tumor with a highly modulated field, we would still expect to gain some information and be able to identify the position of the tumor. Also shown here, if we're trying to track the tumor in the superior inferior direction, which is the primary motion of breathing for lung tumors. What we are really concerned with is identifying the position of the top and the bottom of the tumor. And if we look at the fraction of control points for a particular plan that we analyzed, we found that 90% of the control points actually cover 20% of the superior and the inferior portions of the tumor, as shown in this cumulative histogram. So in a large fraction of our control points, we're actually observing and irradiating portions of the superior and inferior position of our tumor, which means that we should be able to identify where those superior and inferior positions are, assuming that we can improve our imaging quality. Some other things, all of the analysis that I've shown thus far has not relied on the fact that we know a lot about our plan beforehand. So for example, we know which control points, what gain tree angles have high degrees of modulation, which means that maybe we wouldn't trust them as much or weigh them as heavily when we're determining the position of the tumor. So by analyzing plans beforehand, we can not track during highly modulated control points. We can also compare our experimental images to analytically simulated images and really figure out which features we would want to track on in order to overcome these challenges generated by this modulation. So, that's a lot, but in conclusion, we developed this analytical scatter imaging simulation method, which I hope provided some insight into what's happening, what causes these scatter images. This analytical method can be up to 1,000 times faster than Monte Carlo. We also performed phantom experiments using an anthropomorphic phantom, in which we showed that we can identify lung tumors at low clinically relevant dose rates or doses of, for example, 10 mu. We used our QUASAR phantom to show that 1 millimeter lung tumor tracking with scatter imaging is possible, albeit when we introduce modulation, it certainly reduces the accuracy. And then we collected scatter images of 9 patients undergoing lung SBRT treatment. The quality of these images is somewhat poor. It suffers from low photon counts and poor spatial resolution. However, we're hoping to account for these moving forward by using thicker scintillators, perhaps different collimators, positioning our camera closer to a patient. I'd like to acknowledge funding that we've received initially from Swim Across America, and then with Dr. James Chu as the PI, we also received an R21 from NCI. We've also received funding locally from the Alliance Rush Radiosurgery, and I've received a Cone Fellowship as well. So I'd like to thank all of our collaborators and co-authors as listed here, and thank you for your attention.
Great, thank you, Kevin, for a great presentation there. We'll take a look at some of the questions that have been sent in. Your experiments were performed with 6 FFF beams at 1,200 mu per minute. What changes do you expect if 10 FFF beams are used at 2,400 mu per minute?
Yeah, thank you. Yeah, so clinically, we actually have the option of using either 6 FFF or 10 FFF fields when we're irradiating during our SBRT treatments. However, for clinical reasons, we prefer to use 6 FFF just because 10 FFF has a larger electron range, which irradiate a little bit more tissue, and also because the buildup is slower with 10 FFF, and so we might reduce our surface dose to our lung tumors. But 10 FFF, I think, is a very attractive option. There are 2 effects that I can think of. One is that we'll be able to treat at a higher dose rate, which means we can get more photons in these clinically relevant time frames of, for example, half of a second. And then the other interesting result is just that the Compton scattering cross-section results in a more forward-directed set of scatter photons for higher energies. And so depending on where we place our camera, we might expect to see more or fewer photons when we move from a 6 to a 10 FFF beam.
Thanks very much. Would photon counting detectors provide any benefit for your camera?
Right, so I think photon counting detectors are very attractive. They allow us to identify the energy of each individual photon which is detected, which would open up the door to, for example, using a Compton camera, or really performing energy discrimination, which might produce very sharp images if we can identify primary scattered photons compared to multiple scattered photons, which tend to blur the image. So I think there are a lot of benefits to using a photon counting detector. However, photon counting detectors really rely on identifying each photon, and that relies on a very high count rate. And for our treatments, actually our beams are pulsed, which means that we get packets of photons with very low duty cycle, which means that I think the photon counting detectors which are currently available are not fast enough to deal with the very high instantaneous fluence rates of photons that we get during a pulse delivery.
Thanks. Our next question, have you characterized the latency of the scatter imaging system?
So we have not done that. It's sort of a next step for us. And right, the latency refers to that time delay between actually collecting an image and then processing it and acting upon it. So in the feedback loop that we propose, in which we would correct the MLCs or move the couch in order to counteract that breathing motion, the latency would be we collect an image and then we'd have to get to that point where we're moving the patient. And so the latency that we expect is roughly on the 100 millisecond timescale to extract an image from our detector and then to analyze the image using some sort of template matching technique. And then probably another 200 to 300 milliseconds to actually enact, if we went along that route, enact a movement in the MLCs or the couch. And so that means that we'll really need to reduce our imaging time below the 500 milliseconds that we were using for these patient images, because that 100 milliseconds and the 200 milliseconds and whatever image acquisition time will all have to add up to ideally less than half of a second in order to be relevant to really monitor and then act to correct for any breathing motion that we would see.
Yeah. Does the high fluence at the chest wall limit scatter imaging only to deep-seated tumours?
Beam is attenuated as it passes through the patient, which means that anything upstream of our tumor will appear brighter if it has the same electron density as our tumor, which is further downstream. If the tumor is very close to the chest wall, then I think because we're using electron density to discriminate between tumor and everything else, if the tumor is very close to the chest wall and they have similar densities, it will be a challenge to identify and determine the position of the tumor if it is close to the chest wall. But I think with improvements in our imaging quality and in comparison, by comparing experimental to simulated images, I think we will be able to identify tumors, even if, regardless of where they are in the lung. So they could be right up against the chest wall or more deeply seated in the center or in the peripheral or central regions of the lung.
Jerry has more of an observation than a question. He writes, your peak energy seems rather low for an MV beam at 90 degrees.
Yeah, so for an angle of 90 degrees between our incident beam and our scatter detector, we see a peak in our spectrum of between 140 to 220 keV max, with a maximum energy up to around 750 keV. And for an arbitrarily high energy beam, so we're using an MV therapy beam with a maximum energy of 6 MeV. For an arbitrarily high MV beam, you would expect that the highest Compton scatter energy photon that you observe at 90 degrees to be 511 keV. And because we're using a pretty high energy beam of around 6, MEV, it's not too surprising that we see those energies. We're also not looking directly at 90 degrees because we're in fact irradiating a patient volume, which I haven't done the math, but when the beam first enters the patient, it'll be a smaller scattering angle than photons that are scattered out of the backside of the patient or downstream from the beam. So from Monte Carlo and from our analytical simulations, I think those energies are not particularly low or particularly troubling. I think that they're sort of around where we would expect to see, especially if we're considering all the multiple scattering that goes on in the patient.
Yeah, we've got time for a couple more questions. How do you envisage the scatter imaging system being used clinically?
Our vision is that there will be multiple cameras placed within the treatment room and that they will be collecting these scatter images during treatment. We would collect these images and compare them against a library of simulated images that have been generated using a 40 CT of the patient. And based on the quality of images that we get and whether we want to be aggressive about either just monitoring or actually tracking the tumor and counteracting that tumor motion will affect how we use that data, whether we just pause the beam when we observe that the tumor has left the treatment field or whether we actually attempt to move the couch. Yeah, I think it's hard to tell how we'll move forward. It all depends on how good of the images we can get.
We're approaching the end of the hour, so we'll leave the questions there. So on behalf of our presenter, thank you for joining us today, and we will call this the end of the webinar. So enjoy the rest of your days, and goodbye for now.
Thank you.